state if we can get this thing through. I will not spend much of my time talking, but I just wanted to thank everyone here and introduce a few special guests. We've got the Utah League of Women Voters here. Our friend Darlene McDonald, who is a health care reform advocate, and Bishop Siegel from the Episcopal Diocese. Okay, all right. Without any further, I'm going to introduce Dr. Jarvis. As you know, Dr. Jarvis, or you may not know, but most people know that he has been on the forefront of healthcare reform for over 30 years. And what we're calling this is Utah Cares. And what we say is we talk about everything that's wrong with healthcare, everything that's broken with healthcare, and our one great big beautiful idea to fix it. Okay, Dr. Jarvis.
Thank you. The unique American anxiety about healthcare costs has driven American politics for at least 30 years. For the 20 years immediately before the COVID pandemic, Utah voters listed healthcare costs as their single biggest worry, year after year. Like Bill Murray in the movie Groundhog Day, Utahns woke up in 2026 again, facing the music of disastrously high healthcare costs. Annual premiums for a family's health benefit can cost as much as a new mid-sized sedan. Utah is the state with the second fastest growth rate in medical expenditures, doubling the cost of care every decade. Medical debt is a pervasive problem all across the United States, forcing families to choose between eating and treating illness, or between housing themselves and seeking health care. Only in the United States, among first world countries, will you find families going bankrupt because of the cost of illness and injury care. This year, approximately 5,000 Utah bankruptcies will be filed because of the cost of sickness and injury, and most of the people thus bankrupted will have been paying premiums for health insurance at the time they were injured or became ill. Another 2,000 Utahns will die this year because they could not afford medically necessary care. I've lived in Utah for the past 30 years and watched each governor in turn take a stab at health system reform, and they're all failures. I was at the press conference held by Governor Cox a few years ago here in the Capitol when he announced his effort to control healthcare costs, which has been named the One Utah Health Collaborative. Like its predecessors, the collaborative is an attempt to call together the businesses, interests, organizations, and corporations that presently constitute healthcare delivery in Utah and get them to agree to both improve the care that patients receive and arrange for that care to be less expensive. It should not need to be said, but commercial interests do not willingly give up profits or market share. Governor Cox himself has recently been quoted saying, in essence, that though he tried to get the best minds together to solve the healthcare cost dilemma, nothing has happened. He invited anyone with a good idea about reforming healthcare in Utah to get in touch with him. So, last week I sent a meeting request to the governor's office and was promptly turned down. I have also reached out to the collaborative itself, and though I initially had an opportunity to discuss the Utah Cares Act with Scott Barlow last fall, he has repeatedly failed to respond to my inquiries since. I have no doubt that those who are participating in the collaborative are well-intended. They sincerely hope that small, incremental changes to business as usual and Utah healthcare over the planned 15-year time frame of the collaborative will tame healthcare costs. But they are simply doing yet again what has been done several times over during the past 3 decades in Utah, in other states, and nationally. And they will continue to fail. High and growing healthcare costs are baked into the way health insurers, hospitals, drug and device manufacturers, and others do healthcare business. Nothing short of a complete disruption of healthcare business as usual will actually make a difference. There is only one way forward for real and sustainable health system reform. We need better, simpler healthcare financed fairly for all. We Americans have always publicly financed healthcare, and we have always insisted that the care be delivered through the private sector. And our group does not propose to change any of that. But we do propose to put the needs of the patient foremost within the purpose of the healthcare system. Patients need the freedom to choose their own doctor and their own hospital, and they need to know that the care that will be delivered will not financially embarrass themselves or their families. We need healthcare without personal bankruptcy, without medical debt, or without debt due to inability to pay for needed care. American patients pay more healthcare taxes than do the citizens of any other country in the world. The Utah CARES Act will finally give value back to the patients for this generous support. The fiscal soundness of the Utah CARES Act has been extensively and carefully studied. 3 economic studies have been conducted and published in support of this health reform proposal. All 3 of these studies are available in their entirety on the web at www.utahcares.health. The vast majority of Utah patients and employers will pay less for health care if Utah Cares is implemented than is currently the case. We will soon publish an online tool for the use of any Utahn who would wish to compare his or her current costs with what will be true if Utah Cares is implemented. We invite all Utahns to consider carefully whether they wish to continue with business as usual in healthcare or watch healthcare costs double every decade, or alternatively, they wish to support wholesale change in how we finance healthcare in Utah, leading to better care at a gradually reducing cost. The Utah CARES Act is the only health reform proposal ever introduced anywhere in Utah that promises a reduction in the percentage of the gross domestic product in Utah diverted now to healthcare. I've been an active proponent of sustainable health system reform for more than 30 years. I've written 2 books about health reform. I started a Utah health policy nonprofit. I served on the boards of 2 national health reform education and advocacy groups, and produced a documentary film on the subject known as Healing Us. Over those many years of action, I have met with colleagues all over the nation. We who support the Utah Healthcare Act are in good company. There are active proposals featuring similar health policy in many states. To name a few, the New York Health Act. This year, for the first time in 20 years, is endorsed by the majorities of both the Assembly and the Senate. The Pennsylvania legislature will consider a similar bill this year for the first time in 15 years. Colorado's legislature passed a bill designed to study the cost of implementing something like Utah Cares, with the study results due later this year. A similar bill is before the legislature in the state of Washington, where a committee hearing just occurred. Oregon's legislature funded a commission tasked with proposing similar healthcare legislation. I've recently attended and spoken at community meetings after screening Healing Us, both in North Carolina and Nevada, where in both states there are groups trying to organize a campaign to support legislation similar to the Utah CARES Act. Ladies and gentlemen, it's time we get off the Groundhog Day merry-go-round and actually do something to eliminate medical debt, to eliminate medical bankruptcy, and to eliminate the deaths that happen because people can't finance their needed care. We ask you to call your legislator. Ask them to endorse the Utah CARES Act. Tell them to demand that the Utah CARES Act gets a hearing, and then go to that hearing and push for passage. We all need better, simpler care, financed fairly for all. Thank you.
Fantastic. Okay, I screwed up. Senator Blouin was supposed to go first, but that's okay. He's going to now tell you a little bit about the bill that he's running, the Utah CARES Act.
Let's see if I can get this. There we go. Hi, everybody. Thanks for coming out. Hi, Darlene. Good to see you. This has been a fun one to work on. This is a bill, we started over a year ago, I think, with these conversations. So it's been really exciting to see this evolve. So thank you again for being here today. I want to start by saying something plainly. This conversation about healthcare is not going away. It is not going away because the stories aren't going away. We have heard them from working families, from seniors, from small business owners, parents, and caregivers. Stories of people doing everything right and still falling through the cracks. Stories of skipped prescriptions, delayed care, medical debt, and fear that one illness or one accident could upend an entire life. I hear that from constituents all the time. I've dealt with healthcare issues, had broken legs, and carried medical debt for a long time, and it's not okay. This is the reality that too many people are living with right now, and it is getting harder. With the passage of recent major federal legislation, what some folks call the big beautiful bill, I have other names for it myself. Healthcare funding is being cut in real ways. Programs are shrinking, safety nets are fraying, costs are being pushed down to states, cities, employers, and families. When federal support is reduced, the burden does not disappear, it just lands closer to home. Here is the truth: our current system is expensive, inefficient, and morally upside down. The United States spends more on healthcare than any other country in the world, yet millions remain uninsured or underinsured. We do not get better outcomes for that money, just more bureaucracy and more people left behind. So that is why I am introducing the Utah CARES Act. So if enacted, the Utah CARES Act would make 3 foundational changes. It would transition Utah's existing public employee health plan. That's the same one that I get as a state legislator that is fantastic, that I pay very little for, and that I appreciate, and we would love to see more folks have access. So it would transition that plan into Utah CARES, which is a health financing program designed to serve all Utahns. It would establish a Utah Health Systems Commission to oversee health system planning, policy coordination, and health data. And it would create a graduated healthcare tax to replace employer and employee insurance premiums, with all the funds dedicated exclusively to financing medically necessary care. The result is a system that lowers overall healthcare costs, provides universal financing with little or no out-of-pocket expenses, and preserves patient freedom to choose any licensed provider. It separates healthcare from employment, strengthening small businesses, municipalities, nonprofits, and working families. I think this is really cool because it incentivizes innovation and for people to actually find the right fit for themselves and not be tied to one job. So economically, this really matters. Small businesses are struggling under unpredictable insurance costs. Municipal budgets are strained by rising employee health expenses. Families are paying more every year for less security. A universal, publicly financed approach allows us to pool risk, reduce administrative waste, and invest in preventive care instead of waiting for crises. That is not just compassionate, it is fiscally responsible. But beyond the economics, there is a deeper moral question that we have to ask ourselves. What kind of society do we want to be? I believe healthcare should be a right, not a privilege based on where you work or how much you earn. No one should have to choose between paying rent and seeing a doctor. No parent should fear the cost of taking a child to urgent care. No senior should ration medication to make it last. And I, again, hear all those stories far too frequently from my constituents, and it is not okay. The Utah CARES Act is about putting people over paperwork, about putting health over profit and dignity over fear. This is not about ideology. It's about listening to people, to what Utahns are telling us about their lives. And when we listen, the message is clear that the system we have right now is not working. So this conversation will continue. It must continue because the stakes are too high to accept the current status quo. We can do better. We must do better. And together, we can build a healthcare system that truly cares for Utah. Thanks, everyone.
Okay, now we are going to entertain any questions you might have.
Senator Blouin, just curious, how hopeful are you that this might actually pass through the legislature?
It's going to be a heavy lift. I think there are too many folks that are invested, whether it's because of lobbying dollars or just the way that the system operates right now, that they are not going to be willing to make the sorts of changes put here. I think this is a really important conversation to have, though. This is a program that people deserve to have access to, the folks that have been kicked off their health care, the folks that have struggled to pay with the increase in costs because of expiring subsidies deserve to be heard, and I think that's what this is going to be about, and hopefully I think this is it's a fiscally responsible bill. It was unfortunate, I think, to see the lieutenant governor. We tried to run this as an initiative, and someone else may be more prepared to speak to that. But the lieutenant governor essentially said this does not meet the rules required to put on the ballot. I think the folks involved disagreed with that, and so we're going to run it as a piece of legislation instead. And I think we'll have that conversation about how this actually will save us money and save lives as well.
Looking at a passage of legislation like this in the context of a single legislative session shorts the public from really understanding what's about to happen in the next few years. The wheels are coming off the healthcare system. It can't continue. The status quo cannot continue. It is way too expensive. It's ruining family budgets. It's ruining government budgets. Most of the debt that we hear about in the federal government is debt that will accrue because of the costs of Medicare, Medicaid, and other discretionary health programs. So we've got to fix this. Last week, $100 billion in capitalization disappeared out from the health insurance industry in the United States. This past fall, 70% of Americans said the healthcare system is so bad it needs either major changes or it's in crisis and it needs to be completely erased and started over. To believe that just because it's going to be difficult or a heavy lift, as the senator said, to get it through in Utah in this session is to forget all the dozens of other efforts across the country that are making this happen, and somewhere it's going to break through. It might as well be here in Utah. We have a pretty decent healthcare system still that we could support and make it possible for people not only to live through their healthcare, but to thrive economically. And that's not going away. People are demanding this kind of change, and the economy is not going to sustain anything else.
So the overhead for most insurance companies is around 18%. Do you have any current information on what the overhead is for Utah Public Employees Health Plan?
Yes, the Public Employees Health Plan has for years run an overhead of about 4%. That has been true since I first started looking at it 20 years ago. Comparing back then, the rate in the commercial insurance companies was 15 to 20%. You say it's now an average of 18%, but I know of examples that are above 25%.
Well, the Affordable Care Act told them they couldn't go higher than 18%. Yeah. They were around 20-25% before that.
They just learned how to creatively account so they could meet that, and they are actually higher. All right. So, but PEHB runs a 4%.
So that's
or lower
similar to
overhead.
Veterans Affairs and similar to CMS for traditional Medicare. So yeah,
That's in the same
an
ballpark.
important thing to grasp.
Susan.
So for the senator, please. So about the individuals who profit and benefit from the status quo and are going to do whatever they can to preserve it, do you have opportunities either here at the during the legislative session or at other times to speak one-on-one with them and to try and change some minds?
Yeah, I think there are a few folks who are, I think, in a good spot that understand the crisis here, that know how serious and timely this is to move forward here. I think we've seen just an utter lack of interest in actually moving towards anything that would reform the system, and as I have conversations, that people still seem to think that something like Medicare for all or single payer is like too pie in the sky. So it's frustrating. I mean, I haven't had great personal one-on-one conversations with folks that I think are open to this sort of thing, which is scary, because I think, as Dr. Jarvis said, the direction we are headed is totally unsustainable, and it is leading to people dying today. And so I think this is a really good point to have that conversation to put people on the record, so to speak, and to move forward with the conversation, hopefully to see who might be open to actually reforming right now, because I think there's like an acknowledgement that the system is bloated. You know, we hear about pharmacy benefit managers and those sorts of things that just add layers to the system and add costs at every level. And I think there are opportunities to find common ground on some of those. But whole-scale reform like this, I think, is a little bit of a heavier lift, as I said earlier. And I haven't heard a lot of support, unfortunately, which I think is concerning. Because I think that is what we need. There's no other way. There's no reason that, you know, the wealthiest country on the planet can't provide health care for everyone that lives in our communities.
Well, thank you very much for trying to do your part on behalf of this community.
How might Utah Cares affect the rural health in Utah, considering that a greater portion of Utah is located in rural locations?
I'll touch briefly. I think we've seen this, the Health Transformation Fund touted, which is a bait and switch. You know, we lost hundreds of billions, and I think we're getting back 50 billion. So the state is going to lose out in that equation. These rural systems are going to lose out as Medicaid and other programs get cut. And I think this would help, you know, backfill in that area. And so I think that's a general answer, but I think it would be beneficial, particularly as that trade-off that I think the Republicans here have kind of tried to hide and touted this transformation fund I think that was from the Big Beautiful Bill, HR 1, I don't want to call it that. I think we're going to see that's going to be devastating, and that we're going to need programs like this to actually step in and fill the needs of folks.
The underlying principle in American healthcare for 50 years has been make as much money as possible on it. So if you start with that as your premise, and you're looking for a place as a corporation interested in delivering healthcare, you're looking for a place to make as much money as possible, you don't go to rural America. Because rural Americans have more illness, they have a shorter lifespan in general, so the challenges are greater there. The distances themselves are difficult to manage. There's high injury rates. Those are very expensive things to take care of. For a lot of reasons, it's not where you go, and there's fewer people, so you can't make as many dollars off of patient care because there's just fewer cases. So for all of those reasons, American corporations have focused on where the money is and not in rural America. If you drive through the United States, which I have done recently, and get off the interstate and start looking at real rural America, you won't find clinics there. You won't find signs advertising the best health care. You won't find hospitals there. They've all, even though we as a people in the 50s spent federal monies in Hill Burton funds to build hospitals in every county across this country, you won't find them there anymore. They have disappeared. Hospital closures in rural America are a routine event in the United States. Why? Because the revenue streams for healthcare, because of their profit-oriented, occur in urban areas, or at best suburban areas, not in rural areas. What you need in order to support rural healthcare is a system that pays each hospital for its community mission on a negotiated budget basis. So you go to the hospital in that rural community and say, what does it cost? Turn the lights on, pay for the staff. What does it cost to do the care for the people that needs to be done here in the community? And how do we make sure that the cases that need transfer get timely triage and are moved to where they need to be? What does that cost? We find out what that is and we pay it in advance. I assure you, the amount of money we're spending in Utah and all across the country on healthcare is enough to pay for that. And then some. And then the hospitals can start actually on an ongoing basis, hire the staff they need. Those white collar salaries will come back into those rural communities that will build economies that are now gone. They will have the wherewithal, the tax base to have good schools. They'll have libraries, they'll be able to pay for their roads. All of that is disappearing in rural America in large part because the healthcare has been ignored. No wonder rural America is angry about healthcare. They've been abandoned. They feel like the United States doesn't care about them. Where do you think all of this anger and division came from? If we want to heal the United States of America politically and solve these terrible divisions in our country, we need to start putting hands on each other and taking care of each other. And then not only will people have the health care they need, they'll stop being so angry with each other. They'll start loving each other again. Generous acts create more generosity.
We'll start caring for one another.
Yeah.
Okay.
Put it out.
That was a Dr. Jarvis fire word. Right here.
How will this act interface with or relate to Medicare and Medicaid, which are federal programs?
Medicaid is very easy because Medicaid is actually managed at the state level. It's mostly federal funding, which healthcare is largely federally funded, as it should be in the United States. That money is downloaded to a state budget, to a state government, and right now it's handed off to private for-profit managed care organizations, which take 25% off the top and dribble out what's remaining to the poorest of the poor who are struggling to find not just healthcare, but everything that they need. We take that money away from those managed care organizations that are for-profit and hand it off to Utah Cares. And that, in the bill, it's immediate. The transition happens immediately after passage and implementation. That's one of the first steps that we can take, and it's very easy to do. That whole group of people, the funding then, actually, that we get from the federal government will go much further. So many more people, we can expand that group of people. All right, that's step one. Medicare is a little different. It's not state managed. It's an all-federal program, but there is within Medicare a program that is misnamed, Medicare Advantage, because right now the advantage isn't to the Medicare beneficiary, it's to the private for-profit health insurer who uses those regulations to create revenue stream for themselves. But we'll use that Medicare Advantage program and create a Utah Cares Medicare program, and it will pay all of the premiums for all Medicare beneficiaries. It will expand the services that Medicare beneficiaries can receive to include things that now are not included, like hearing and dental and vision. We'll also eliminate other out-of-pocket expenses that Medicare beneficiaries have included, especially in Medicare Part D, which is the drug benefit, and therefore offer to the Medicare beneficiaries, such as myself, I'm on Medicare, in Utah, a much better deal. We can't force them to change over to Utah Cares, but I'll go. And I think a lot of people will follow me. That's how we'll handle this.
On the fiscal side of things, I was just curious, this Utah Cares premium says it would raise about $10 billion, which is about a third of the state budget. What would that tax increase look like on businesses? That's what that amount would be?
Yeah, so it's a tax on business transactions that's at its peak. The highest level for the businesses that pay the most will be 2.85%. For a lot of businesses that have very small employee bases or very small revenues, there won't be a tax. So it's somewhere between 0 and 2.85% for businesses, raising $10 billion and replacing the $16 to $20 billion that employers currently are paying for health benefits. Every employer will therefore be able to just back out of the health benefit business and let it go and not worry about it anymore. There'll be a better benefit package for their employees under Utah Cares than any of them can possibly pay for right now.
Thank you.
Yeah, I think it's easy to say this will be good for business. It'll be good for employees. It'll allow them, again, to move around, to find the right fit for them, to not be stuck into one job because they have healthcare benefits tied to that position. And so it's critical that we actually take that seriously. I think there's just this illusion that paying more by businesses is going to somehow hurt the economy, but we know from the numbers here, from the opportunities that this will open up for folks, that it's actually going to be a very helpful, I think, strengthen our economy and move us forward in a way that's actually good for the entire community, and yeah, get the employers out of the healthcare business that they never were designed to be in. I think that allows them to focus on their core mission rather than all the other bits and pieces that they've ended up managing over the last few decades.
If you really want to get into the weeds of this premium, speak with Mr. Tom Young right there. Tom, raise your hand. He's the economist who wrote the report that's on the website that I mentioned. which specifically deals with how much do we need to levy in order to replace employer costs in healthcare, employer and employee costs in healthcare. So there's the weeds right there.
My question is, this makes sense. I mean, this is common sense. What's some of the pushback that you hear regarding why we cannot implement
I mean, honestly, some of it just seems like cruelty. It seems like there are people who believe that not everyone who is in this country should have that access to care, just to be very blunt about it. And I don't know where that comes from. It's very frustrating, but we can do better than that. And I think we have to keep moving forward a direction that actually will take care of the entire community. So I think it's this illusion that it's going to be bad for business or lead to worse care or things like that. But we know this is going to leave people with the same providers they have now. If they want those same providers, hopefully open up access for a lot of folks who want something better than they have right now and reduce the cost for them as well. So I think it is a no-brainer. It's common sense. But there's just so many misconnections, I think, for so many folks in this sense that people don't deserve health care or something like that. And I think that's just patently false, and that we should, again, as the wealthiest, most profitable nation in the country, in the world, we should be able to provide for our entire community in that way. So this is a way of showing that we actually are serious about that. And I hope that the people who for whatever reason do feel like we need to prioritize one member of our community over another, that they can step back and take a look and see how this will benefit everyone, see how opening up care to more people will lower costs, will prevent those emergency room visits and things like that. And I think there's so many pieces that are common sense that having the conversation, hopefully shedding some light on that here in Utah, will actually bring some people along that maybe don't have that feeling right now.
Yeah, there are people who just overtly say that not everybody deserves health care, but those who want to be more genteel in their pushback, what they'll say is it's a market. We need to let market forces prevail. And almost all the arguments you'll hear coming out of the One Utah Health Collaborative or any of these other efforts that have gone on across the country for years and years now is based on the concept that somehow healthcare is a market commodity and market forces, the invisible hand, they say, of Adam Smith, should be allowed to prevail. And so everything they propose, like health savings accounts and high deductible health plans, they're all based on this concept that somehow patients need to be buyers, and they need to be buyers in a market where they're making their own decisions and have their own choices between health plans. And of course what health plans do is actually restrict choices, right? That's what they do. That's their whole market model. So to answer back on that is to basically say healthcare is not a market commodity. Adam Smith described what a market commodity was, what it had to be like. And healthcare is not any of those things. Market commodities have to be something that the buyer must be aware about. They must know everything about, so that they can look out for their own interests out there on the market and make the right purchase for themselves. Well, I'm sorry, healthcare is not sold to buyers. It's given, it's provided to patients, not on a competitive basis. If you want to do healthcare right, you cooperate in a community. You have a trauma system that has a way of getting people within that golden hour, first hour after trauma, to where they need to be. You have a cancer center that knows how to do it for every single different kind of cancer, all the 100+ odd cancer, and treats patients according to that best known protocol that's been published. Those things are not something that patients know about. They can't buy that. They can't think through that. I've trained for 10 years to be a physician, and when I get sick, I can't think, I can't get up, I can't go shop, I can't do anything except hope that my doctor knows what he or she's doing. That's what we all do. We all throw ourselves in the hands of a physician and try to get hope for the best care because we've tried to pick the right person for us. And doctors, on the flip side, in a market, the seller of a service or a good has to be in that selling only for one reason, to make as much money as possible. Well, that's actually a contradiction of the Hippocratic Oath. We tell doctors and nurses and other health professionals that they aren't supposed to look after themselves first. They must look after the patient first. That's not a market commodity. In a market, when there's a transaction, it only matters to the buyer and to the seller. In healthcare, actually, that's not true. It matters to me whether the case of tuberculosis walking around on the streets of Salt Lake City actually gets the care that he or she needs. That matters to all of us. The trauma case, if it isn't handled properly in a community shared process, then when I need that trauma care, it's not, those doctors and nurses aren't going to be well practiced. They're not going to be able to do the right thing for me. Open heart surgeries like that, burn units are like that. You do them best when you concentrate them and cooperate in a community. That's not a market. And finally, a market commodity is something where the price is flexible and sensitive to the demand, or inversely so, okay? So as the price goes up, the demand for a market commodity goes down, right? You don't sell as many Mercedes because they cost more than whatever that low-end car is, right? That's the price sort of inverse relationship to demand that a market, nothing about that is true in healthcare. I often use as an illustration diabetes and the cost of insulin. I'm not a diabetic. I don't need insulin. I don't care how low the price for insulin goes. I'm not going to demand insulin. It's not going to change my interest in it, right? Because I don't need it. The demand for insulin is based on epidemiology. What's the rate of diabetes? It has nothing to do with the price of insulin. If, on the other hand, I were insulin dependent as a diabetic, I don't care how high the price goes. I have an inflexible, inelastic demand for that product because I got to have it or I'm going to die tomorrow. There is no inverse relationship between price and demand in healthcare. It's not a market commodity. That is what we have to tell the people who are fighting us on this. Market forces will never work. We have the most marketized economy in healthcare in the world, and we're still gasping for breath.
That was a speech. I would just second, I think the point about treating healthcare as a market commodity is absolutely right, and that we should not be treating basic needs like healthcare, like housing, like food as markets in the purest sense of the form. So it's so important to reflect back on that, and also to, I think about the influence that these big corporate lobbying firms and these big pharma companies and the healthcare companies lobbying to keep the system intact as it is, that are funding legislators here and politicians in DC. We need to take them out of the equation too, because that certainly keeps the status quo operating as it does right now.
Do we have a feel for how many people in Utah are employed in the health insurance industry? I know this might be healthcare bills come from California now, so maybe that is an appropriate question. But
It's hundreds of thousands who are administrators, and that's where the growth in health system employment is. For many, many years now, and I would say 4 decades, the growth in physicians and nurses is very, very incremental. We are far behind what we should be in terms of per capita physician and nurse numbers. But administrators are asymptotically growing. And so hundreds of thousands of them. If you think about the brokers who sell insurance and the agents who are out there and all the people who sit somewhere in the United States and look over applications for care, pre-authorization, et cetera, there are millions of those people. That's where, yes. And so that's where people are employed.
All right. One more question. Anybody? Go ahead.
Will this cover mental health services as well?
Yes, I think dental as well.
Yes.
Yeah, mental, dental, all those good things. Vision. We need to protect those services and make them as universal as possible. So, again, the coverage that I have as a state legislator, I think, is what I would like to see everyone have access to at an affordable rate, and that is what we were trying to do here. And certainly, we know how important it is to have health parity with mental care and with all the other services across the range there. We can't let people just continue to suffer. Because it's feeding into our homelessness crisis, it's feeding into problems we have in schools, all of those things. And so it's so critical that everyone has access to all of those pieces.
All right. Thank you. I'm going to open this up now if you want to do individual interviews with either Senator Blouin, Dr. Jarvis, or Mr. Young, we would welcome those interviews or questions in one-on-one time. So thank you so much. We're so glad that you're all here, and everybody have a beautiful Monday. Happy Groundhog Day. Oh, Dan has a word or two.
Oh, well, I was just hoping we could